So there was a question about low dose naltrexone dosing question, but this is the opposite of the microgram, which is higher dose. So for, I think the question should be answered by the person who is prescribing it, and if possible, they should back it up with primary research or review article. Primary research means they actually did a clinical trial, and that uh, the results should be um, somehow related to that. And the second best way would be a review article that has an opinion. The third would be an expert opinion. So, and those are all acceptable because naltrexone or low dose naltrexone or ultra low dose naltrexone is still new. So to answer this question, I'll go back to the video that I did on tinnitus. When we did the tinnitus, we do have a study that shows comparison of treating tinnitus, which is auditory nerve condition and the brain condition. So if we believe that naltrexone or LDN can calm down nervous system and calm down immune system, even though tinnitus may not be usually autoimmune related. I had one that was autoimmune related, and that person had hearing loss, tinnitus, and LDN cured her, reversed her hearing loss, and also reversed her tinnitus. So outside that, really, my personal results have been plus minus, meaning what do I mean by plus minus? Plus minus means 50% or less. Usually, when I use any tool, let it be acupuncture, supplements, or low-dose naltrexone, methylene blue, or rapamycin, it has to be useful about 70% of the times. The reason is that, um, at least acupuncture, they say the placebo results or non-specific insertion of needle results can be as high as 50%. So 40 to 50%. So I want a double of that, which is 70 to 80%. And not always I get that, which means that I'm lukewarm on it. So the study showed, compared 5 milligrams of naltrexone, 12.5 milligrams of naltrexone, and 50 milligrams of naltrexone with 0 milligrams of naltrexone. And the results showed that all the naltrexone showed an improvement, but when you really drill down, the 50 milligram statistically had better results than 5 milligram, 12.5 milligram, and 0 milligram. Or the 0 milligram had the worst effect, and the older LDN had better effect. But the thing is that statistically better does not mean clinically better. Let me explain to you this way. If your child has been getting, let's say, 50% in the exam, that's nothing to celebrate. I think that means failing in most countries. And statistically, 60% may be better grade, but still that's not a grade to celebrate. So if it's 70, 80, 90%, 100%, I think that's kind of what I look at it as. Is it statistically significant, clinically significant? So, and the result really, LDN did improve, but not clinically significant. And that is actually very consistent with my clinical um, observation that LDN alone does not seem to clinically be relevant for treating tinnitus. Why is tinnitus? The question really wasn't about tinnitus. The question was, what does the high dose naltrexone do for immune modulation? I think that for immune modulation, I do push LDN beyond 4.5 milligrams. I go to 6, 9, 12, and then I stop at 24. The reason why I stopped 24 is that 15 milligrams of naltrexone has a black box label or warning for hepatic function or liver function. So if you're going to use 50 milligram and above, you should really check liver enzymes regularly. Now, studies also indicate the problem with liver happens not at 50 milligrams usually, but beyond that. But because naltrexone is available at 50 milligrams, I treat that as not low dose naltrexone. That I consider that the standard pharmacological dose of naltrexone at the lower end, but so I don't even like prescribing it. I have had experience of prescribing it a couple of times. Both of them was not for immune modulation, it was for inflammation purposes. This one person was suffering from steroid-induced psychosis. And steroid should be anti-inflammatory, but in people's body and in medicine, you cannot just say be dogmatic about anything, including steroids being anti-inflammatory. Yes, it's anti-inflammatory for most of the people, but there are people who are allergic to steroids. There is a condition known as steroid-induced psychosis. So in this person, it was quite severe, and I was really beginning to be afraid for safety. And because the person was taking 24 milligrams of naltrexone, I did ask the person to double up on it, and the person said, "Oh my God, all the dark thoughts that I have is gone, and I no longer have to go to psychiatric emergency room to make sure that I'm safe." And this person also happens to be a licensed mental health professional, so I had some confidence in that person's assessment. But I would say in general, I don't like going over 25, not because it doesn't work, because it blurs example of what I do. So for example, when people say, oh, why don't you use a low dose antibiotics for treating MCAS? I don't like doing it because the antibiotics can have quite serious side effects, such as a C. diff infection and then causing uh, really bad GI issues, and I just don't want to be party to that. I will use methylene blue. I will even consider rapamycin that is in low doses occasionally, but I will not. I have more inhibition using um, antibiotics for that purpose. Now, if the person has infection like Lyme disease, then I think that we're kind of trapped into using antibiotics. But if I can avoid using pharmaceuticals, I always try to use an alternative to pharmaceuticals if possible. Now, having said that, LDN is a pharmaceutical. I love using LDN because the dose is lower so that it doesn't really create problems with the liver at the doses I'm using. So this is Dr. Kim, and if you learned something, please share this and like it and subscribe. And if you have more questions, you can join us at at in the Facebook group LDN support group, or you can visit my website www.yunhangkim.com. Thank you.